Bismillahirrahmanirrahim. I welcome you all to the Industrial Symposium session, which would be chaired by Dr. Qadir Ahmed, and I'm pleased to give his introduction. Dr. Qadir Ahmed is a medical graduate from Dow University of Health Sciences, MCPS in Family Medicine and Masters in Diabetes and Endocrinology. He is associated with the Diagnostic Division of Roche, Pakistan Limited since last 17 years. During his tenure, he led senior roles in marketing and management, and currently he is heading the medical and scientific affairs department. His portfolio, his interest includes cardiology, metabolic syndrome, women health and oncology, especially HPV and cervical cancer. Now, I welcome Dr. Qadir Ahmed to come onto the stage and take his share.
Bismillahirrahmanirrahim. Assalamu alaikum and a very good afternoon to ladies and gentlemen. I am extremely grateful to ICCBS, the whole team of ICCBS, and particularly Dr. Iqbal Chaudhary and Professor Thomas Hittner for providing us with this chance to participate in this highly educational and scientific event. Roche being the world leader in the field of diagnostic, it's always our effort to come up with new and innovative diagnostic solutions which can bring positive change in patients' lives. We spend more than 10% of our annual budget in research and development, and this shows how serious we are. Especially HPV is very close to our heart because having such a large prevalence in this part of the world, there is a dire need to educate people and create awareness about HPV and cervical cancer. And I'm again grateful for this opportunity with Roche to participate in this session by having our regional speaker who will share her thoughts. But before that, I would request the organizers to play a short video. this session, we have two notable speakers from the Asia Pacific region who will share their thoughts on cervical cancer and HPV. Our first speaker is Dr. Ida Ismail Prar. She is Medical Director, Ops and Guidance Center, Mount Elizabeth Nomina Specialist Center, Singapore. I would request Dr. Ida to share her thoughts with us.
Good afternoon, good evening, everybody from Singapore. I'm going to be sharing my slides now. Thank you very much for giving me this opportunity to talk to you about HPV and cervical cancer. As you know, as everybody's aware, my name is Dr. Ida Ismail, and these below are all my affiliations. So just like to highlight as well that, you know, I do lead the IPVS ECHO meeting, and what we do is a telementoring program where we invite clinicians as well to discuss their HPV-related diseases with experts in the IPVS in order to help them manage their patient. Now, I've been told that in this audience right now, a lot of research experts and academicians, and I can tell you that I'm an OBGYN specialist. I am a clinician. I'm not really a research or academician. I dabbled in a little bit of research, and myself, I am the self-proclaimed advocate for cervical cancer prevention. And I thought it would be a good way of actually doing this presentation to you as a clinician perspective, because I truly believe that any research related to papilloma virus, HPV, any research towards cervical cancer prevention, that our goals certainly is towards a positive clinical impact, i.e. to make sure that all women don't really get cervical cancer. These are my disclosures. I'd like to introduce you to this first, and this is cervical cancer. This is from my patient. One is late 30s and one is early 40s. We know that most cervical cancer has no symptoms, and women keep on waiting for symptoms, but when symptoms appear, it usually is in the late stages. Once a woman is diagnosed with cervical cancer, we know that she is then succumbed to various management that are a major impact to a woman's life and the life of the people around her. This can involve surgery like radical hysterectomy that remove the woman's uterus and renders her permanently infertile. And she may have to go for radiotherapy, chemotherapy, and get exposed to the risk of major surgery, chemotherapy, risk of radiotherapy, and also premature death. Now, the thing is with cervical cancer, we know that it is preventable because this is the only women cancer at the moment that we can actually identify the stage before cancer. And we can actually destroy the area with what we call the pre-cancer stage effectively so that this does not happen. It's easier said than done. And we will talk about that in a few minutes so that cervical cancer do not happen. And this is the culprit here, which is the human papilloma virus. We know that the human papilloma virus essentially is the cause of cervical cancer. And this comes from a very famous paper, as you know, that was published by Wall-Bloomer in about 20 plus years ago, saying that human papilloma virus is the necessary cause of invasive cervical cancer. This is following him doing a Hpv Dna test on women with cervical cancer and found that 99.7% of cervical cancer is caused by high-risk HPV. You know more about this than I do, but we know that most human papilloma virus that causes cervical cancer comes from the alpha papilloma virus group. As clinicians, this is what is important to us. We know that cervical cancer, 99.7% is high-risk HPV related. We know that 70% of cervical cancer is caused by type 16 and type 18. We also know that HPV is a very, very common infection, easily transmitted by skin to skin, including sexual activity, and it is as common as the flu virus. Most of us in the audience would possibly be exposed to HPV at some point in our lives. And luckily, most infections are actually transient infection, therefore does not increase our risk of having cervical cancer or HPV-related disease in future. What we know is that there's about 200 types of HPV, but not all of them causes cervical cancer. This is by IARC monograph that was published in 2012 that recognized that type 16 is the one with the strongest evidence to be carcinogenic in humans. Then there's other 11 that this is a systematic review meta-analysis of the published paper on HPV-related diseases, especially cervical cancer. And they can say that 11 types there is also having sufficient evidence to be carcinogenic in humans. If you do notice that most HPV assays will be checking for not only type 16 and type 18, but also non-16, 18, which include 12 other types that are included as high risk. And these actually include 68 and 66. But currently, these are just seen as probably or possibly carcinogenic, but a very limited evidence to this. We also know that other types such as type 6 and 11 causes 90% of genital warts, and these are not classified as carcinogenic, but it is important as well because this is the most common non-cancer related HPV infection worldwide. And what is the risk associated with specific genotypes? And this old paper as well showed you that, if you do have any of this type of infection, when you compare to controls who do not have this infection, the odds ratio of you having cervical cancer is in the hundreds. And putting it into perspective, if you have HPV 16 positive compared to a woman with HPV 16 negative, your risk of cervical cancer is increased by 434. But if you are a male smoker compared to a non-smoker, your risk is only increased by 8. And if you're a woman with taking HRT, your risk of breast cancer is only 1.3. We all know the cause of cervical cancer, and we also know the development of cervical cancer from HPV infection. We know that the infection is asymptomatic, and majority of this HPV infection is transient. However, we don't really know yet, and maybe this is something research can think about, is that we can't really identify which women will have a transient infection and which women will actually have persistent infection when they are exposed to the high-risk HPV. Therefore, all the national or all the cervical cancer screening program that you find worldwide is a blanket rule that all eligible women must be screened for cervical cancer when they reach a certain age. And that's a lot of women to screen, but can we actually refine this a little bit better? We also now know that every child, when they reach a certain age, should be vaccinated as well, because we still are not able to identify who will get a transient infection in future and who will actually get persistent infection that causes cervical cancer. And we know that from infection to cancer can take up to 30 years. But in that 30 years, 90% of women will actually heal from the infection within 2 years without actually doing any form of intervention or invasive procedure. This is another graph to show you the prevalence of HPV infection and also cervical cancer. You can see that when you are young, the prevalence of HPV infection is very high, but the incidence of cervical cancer is quite low. However, the older you are, the chances of you having HPV infection is much lower, but the incidence of cervical cancer is actually higher. And this shows you the mechanism of cervical cancer from HPV infection, well, when you're young, it's transient infection and you get rid of the infection without increasing your risk of cervical cancer. While you're much older, it's more likely that it is a persistent infection. I would be more worried if a 50-year-old lady has HPV 16 positive compared to a 25-year-old lady with a HPV 16 positive. This also gives us a little bit more understanding on how to prevent cervical cancer and the services that we need to develop to prevent this. We know that in their 20s, that is when the highest prevalence of infection. However, most of them are transient. But the women, the group of women that we need to target to save them from cervical cancer are the ones in their 30s, their 40s, up to their 50s, because these are the group of women that will develop pre-invasive cervical disease. Now, pre-invasive cervical disease, and some of us call it CIN3, CIN3+, these are actually not cancer yet. It's the stage before cancer, and we clinicians can identify this. We can actually treat it effectively, thus preventing the woman from getting cervical cancer. So how do we prevent cervical cancer? We have great tools nowadays to prevent cervical cancer. The first tool is HPV vaccination. This is the first line defense. You protect the woman from future HPV infection. Therefore, if you don't have any infection, you will not have cervical cancer. We know that HPV vaccination is effective. We know that the most effective delivery of HPV vaccination is a school HPV vaccination program. However, for those women who are already exposed to cervical cancer, we can still protect them from cervical cancer by the second line defense, which is screening and treatment. This is, yes, damage control, but we can still remove the disease before actually the disease develop into cervical cancer and still prevent the woman from getting cervical cancer. So just to tell you that currently, globally, there are 3 types of HPV vaccine, as a bivalent, quadrivalent, and nonavalent. And we are hoping that in future, there are more HPV vaccine coming our way to stop this, what I call the globalization of HPV vaccine. All the vaccines protect you from type 16 and type 18 equally effectively. But the difference is the other extra protection, as you can see, for bivalent vaccine, protects you from 2 of the 14 cancer-causing HPV, and Gardasil is the same, but Gardasil also protects you from type 6 and 11, which causes genital warts. But the most recent one would be Gardasil 9, and this is a nonavalent vaccine where they protect you 7 of the 14 cancer virus that we know, and giving the protection up to 90%. In terms of giving the vaccine, this is how the vaccines is licensed in Singapore. This both licensed for boys and girls. The earlier you give it, especially between 9 to 14 years old, it works better. You can give it to older women and men, but it doesn't work as well as if you give it to the much younger generation. Hence, the school HPV vaccination program is one of the successful HPV vaccination strategy worldwide, because it targets boys and girls around these ages, especially around 12 and 13 years old. And we know that this is a prophylactic vaccine. This does not treat whatever HPV infection that you have been exposed to. It protects you from future HPV that you may be exposed to in future. There's no virus in the DNA in the vaccine. WHO has over and over again established the safety of the HPV vaccine. You cannot get an infection from a HPV vaccine, but it helps you build strong immunity to fight future infection. As you can see, no booster at the moment is required. Currently, you can give a 2-dose regime to 9 to 14 years old and a 3-dose regime for 15 years and older. And how well does the vaccine work? And this is also one of the very first data from Australia. And we know that in Australia, they are the first one to introduce school HPV vaccination program in girls. And what they found after following them up for 5 years is not just the girls, they used Gardasil at the time. And it's not just the girls that have a reduction in the incidence of genital warts, but they also found that the incidence of genital warts is also reduced in boys, even though the boys did not get the vaccine. And this is one of the first evidence of herd immunity when it comes to HPV vaccine. And currently, most countries and experts do advise in terms of gender-neutral HPV vaccination. When we talk about second-line defense, you cannot just talk about screening. You need to talk about screening, diagnosis, and treatment for you to prevent cervical cancer. There is no point of having a screening tool without the ability to diagnose pre-cancer and to treat it. So all three have to work together. And how to screen for cervical pre-cancer? Currently, there are various ways. You can use visual inspection with acetic acid in where most low and middle income countries used. Now, certainly a lot of experts would say that VIA is not one of the best way to screen for cervical cancer. However, in terms of the challenges that you have in low middle income country, if you have no other facilities for apart from VIA, that's probably better rather than having nothing at all. The more common way to screen for cervical pre-cancer is by doing cytology using a pap smear and an HPV DNA test. Now, we also have HPV test self-sampling, and there are increased evidence to say that the efficacy and the sensitivity of the HPV test sampling is as similar to physician sampling as well, and we will talk about this a little bit later. So why HPV DNA tests? For me, and for every clinician that does cervical cancer prevention, HPV DNA test is one of the game changer in terms of cervical cancer screening. It is an objective test. You don't have the subjective results that you get from cytology. You get either HPV positive or you get HPV negative. It is a much more superior test than cytology because the sensitivity in detecting high-grade CIN is better. We know that HPV DNA test has the ability to predict the risk of CIN3 in future. And this is important to me as a clinician because I can advise my women better, especially when they have positive HPV test. When you have a positive HPV test, a lot of what you need to understand, there are a lot of psychological stress on morbidity for these women as well. And HPV test, the risk and the counseling is much better when you know the risk of them developing CIN3 in future. It also has a very strong negative predictive value. We know that a negative HPV test gives you a really strong prediction that the chances of getting cervical cancer or CIN3, at least in the next 5 years, is less than 1%. And also it allows for longer screening intervals. And for those of you in the audience who has had a cervical smear done, it is not a comfortable procedure. It's something that a lot of women do not go to. And then this is the main barrier of cervical cancer screening. And allowing a cervical screening to be of a longer interval is actually a welcome to all women. We also know that if you do both pap smear and HPV test in clinical practice, the HPV test has a much stronger affinity to help me with and guide me to my management of women compared to a pap smear, because it shows that if you have a negative pap smear but a positive HPV test, your risk of getting cervical cancer CIN3 in future is still increased. So I still have to monitor the women even though her pap smear is negative, because as you know, the sensitivity of a pap smear is not very good. But if you have a positive pap smear, but your HPV test is negative, then the risk of her getting cancer or CIN3 in future over 6 years is still very low. And in a population-based screening, we now know that co-testing, which is doing a pap smear and HPV test together for primary cervical cancer, offers very little benefit compared to just doing HPV primary screening, which is doing HPV DNA test alone. And when it comes to treatment, it hasn't changed for the last 20, 30, 40, 50 years. We either destroy the area of pre-cancer or we cut the area away. And there are various ways of doing it. It's a very effective treatment, and but it's individualized to women and depending on the facilities that you have in your country. These are all really very straightforward, and we were wondering, okay, why, if it's still straightforward, why are we still talking about HPV? Why are we still not eradicating cervical cancer? And why is it that WHO has to make a call to action in 2021 on cervical cancer elimination strategy by the year 2030, where it calls out for all countries, may it be high-income country or middle-income country, that by 2030, the goal is to have 90% of girls fully vaccinated with HPV vaccine by the age of 15 years. We need to have 70% of our women to be screened with a high-performance test, and a high-performance test currently considered is HPV tests. And they should be tested by 35 years and 45 years of age, and 90% of women who are identified to have cervical disease to receive treatment as well. Now, this is a big challenge, especially for LMIC as well. Can we actually reach the goal that is being put forward by WHO? Well, Australia is doing it, and I see that Suzanne Garland is actually in the audience as well. And Australia has been our example of how to actually screen for a cervical cancer screening. As you can see, they are the first to introduce a school HPV vaccination program, introduce gender-neutral HPV vaccination in 2013, introduced nonavalent HPV vaccine in 2018, and also establishing an organized HPV-based cervical screening. And they are more than on their way to eliminate cervical cancer in Australia. Can we mimic this data in other countries? Can the low middle income country actually mimic the cervical cancer prevention that is we see in Australia? So what's happening to the rest of the world? So despite being preventable, every 2 minutes that I've been talking to you, a woman somewhere in the world is dying of cervical cancer. We know that in the last year, there's about just under 600,000 women diagnosed with cervical cancer, and about half of them died of this preventable disease. We know that it's the 4th most common cancer and the 4th leading cause of death in the world. And we know that majority of the cases and majority of the death are in lower resource countries. And 60% of the cases at least are in the Asia Pacific. So what are the barriers that is the reason for this still being one of the leading cause of death in women, especially in the Asia Pacific region? This is a recent publication from Chua et al. That looked at the barriers and facilitators to screening. So the main barriers that was found in the women in the Southeast Asia is that knowledge of screening is not there. And it's not that they cannot absorb the knowledge, but more because the knowledge is not easily available. Perceived susceptibility. And that basically means that most women think that because they're healthy, they do not need to go for screening. Most women also wait for symptoms, but we know that if you wait for symptoms, then chances are you will already have cervical cancer. But one of the major barrier in the LMIC is still costs and health center characteristic in terms of manpower and location, and the providing the services of cervical cancer prevention. We know as well that a woman is more likely to go for cervical cancer screening if she is much older, and also when we as healthcare workers advise them to go to screening. However, in terms of age, we don't really want women to realize that they need to go for regular screening when they're much older. We need to actually for them to realize in the younger stage, because that's when we can actually prevent cervical cancer. So how do we prevent it? And what I see in terms of preventing cervical cancer is not, it's encompass a lot of aspects, but access is one of the main key. Access, when I talk about access, is about access to awareness and knowledge, access to training for the healthcare workers. You have to have access to the prevention tools, your HPV vaccine, your pap smears, your HPV DNA test. You also have to have access for prevention services. When we have this, access determines your uptake, and uptake determines how successful a cervical cancer screening strategy is, especially when we're trying to reach the WHO call for action, the 90-70-90 that has been mentioned before. And how do we increase the uptake? WHO has also published a publication to show that for the health system to help in prevent cervical cancer, there are 6 main building blocks. You have to access to service delivery, to health workforce, information, medical tools, technology, financing, and leadership and government support. It's not just about access. Even if you have access to awareness, prevention tools, and prevention services, are they effective in providing the goal that you are wanting? And effectiveness in your delivery of the awareness and training, the effectiveness of the screening tool and the vaccine, effectiveness of prevention services, all leads to cervical cancer prevention. So always remember that we talk about cervical cancer screening. We are screening healthy women. We want to screen them with minimal clinical and psychological risk exposed due to over-screening and over-treatment. We do not want to screen a healthy woman and then expose them to other clinical and psychological problems. So these are some of the awareness campaigns and that has been done. As you can see, IPVS has launched HPV Awareness Days. It's on the 4th of March of every year. And this last year, it has launched One Less Worry. We also have webinars in the IPVS for clinicians and for research fellows as well, in terms of understanding more on HPV and cervical cancer prevention. And I would urge you to check out the IPVS website and the Education Hub as well. But is awareness campaign and training the only way we can increase the uptake and access to women? Well, in Singapore, it's not really, because in Singapore, we do have a cervical cancer screening program. And as you see from this small graph here, that we did a survey on women, and majority of women, about 90% of women, know that the importance of going for regular screening. But our uptake of screening is still just less than 50%. The government has also introduced a lot of incentive to go for screening, including just paying $5 or $2 for you to go for cervical cancer screening. But the uptake has not changed for the last 10 years at least. So we know that relying on improving awareness, knowledge, and training is not enough. There must be more. And at the moment, access and effectiveness has to work together. And these are the current game changers in cervical cancer screening. As I said before, self-sampling is one of the major game changer. And I think this is the one that is going to help to increase uptake in cervical cancer screening, especially in the LMIC. And so is thermal ablation. I always say that the speculum is the biggest barrier in cervical cancer screening. It is an uncomfortable examination. Women do not like going for their cervical screening because it's embarrassing. There are also some of the doctors or the healthcare workers also are not sure how to perform a speculum examination. And all those barriers are taken away by giving the woman control over her cervical cancer screening by self-sampling. And we know that self-sampling, sensitivity of self-sampling is similar to a physician sampling. Another game changer currently is the WHO has just made an announcement that the one-dose HPV vaccine does offer solid protection against cervical cancer when compared to 2-dose regime or 3-dose regime. And this is a big game changer, especially for LMIC, because you then eradicate the barrier of follow-up for these women to come back for the 2nd dose and the 3rd dose. It's also overcome the barrier of cost. And the other game changer in terms of treatment for cervical cancer is the thermal ablation, which is a portable heat treatment, which is very effective in treating pre-invasive disease, because one of the barriers of women, even though they are found to have an abnormal pap smear or HPV DNA test and they are found to have pre-cancer, they may not be able to come for treatment because 1 is too expensive, 2 is too far. Now treatment can go to them. And the training for thermal ablation is not as involved as if you want to do other treatments such as a lead procedure or a cone biopsy procedure. So these are the current game changers. I'm hoping that in terms of cervical cancer prevention in HPV, and for all of you in the audience, that you will help also to introduce further game changers in this to help women to prevent cervical cancer. Now, as a clinician, these are still the questions that I want to be answered. And I'm still asking this question. In terms of HPV vaccine, is there actually a better prophylactic HPV vaccine? There are now several studies in China, and there's also India has also made an announcement of a prophylactic HPV vaccine that they have invented. What we need is not just a better in terms of effectiveness and also cost. And we know that the main barrier, one of the main barriers is access to HPV vaccine in the low middle income country is cost. What is the role of therapeutic vaccine is it ever going to be a reality? Should we give HPV vaccine to babies instead? And the other questions that I'm still looking for answers, and this is where research comes in. And screening, diagnosis, and treatment. Is there a better screening modality than self-sampling? People have looked at urine, people have looked at menstrual blood. Is there any other way to screen risk of cervical cancer for women that doesn't involve women to actually keep on coming to see the doctor? Is there an easier way to do it? And also a more sensitive way of doing it? Is there a better way to diagnose pre-invasive disease compared to just having colposcopy and biopsy done? We need better biomarkers. Are there any other biomarkers that we can do to detect HPV, not only persistent HPV infection, but also pre-invasive disease? Is there any other treatment? Because the treatment for pre-invasive has been going on, the same treatment has been going on for years. Is there any other treatment that we can offer women to that will not expose a woman to obstetric morbidities in future? So these are some of the questions, and I hope that you as the research community will help to answer these questions in future. So in conclusion is that cervical cancer is preventable. Effective cervical cancer prevention to exist, we can eradicate cervical cancer. We just need to have access to it and also the effectiveness of not only the prevention tools, but only the awareness method and the services, delivery of services of these prevention tools. The best campaign, the best tools, and the best skills, and the best vaccines are useless without access. And continued support and research in all aspects of cervical cancer prevention is still required to continue to improve access and effectiveness of cervical cancer prevention, especially for the LMIC. And with this, I would like to take home message is that in terms of cervical cancer prevention, it's not only about HPV vaccination, screening, diagnosis, and treatment. It is also about research. All of this has to work together for us to improve our current cervical cancer prevention and make sure that more women do not get cervical cancer. Thank you for your attention.
Thank you very much, Dr. Eden, for such a nice and informative presentation. And it did answer a lot of questions that were present in our minds. Please do stay with us because we are going to have a question answer session after the second presentation. Now for the second presentation, I would like to invite our regional colleague, Andrea Vijvira, who is APAC Business Manager for Molecular Lab, HPV and STI. So over to you, Andrea.
Thanks, Kadir. Hi, everyone. Really good afternoon to you. And thank you for your attendance today. All right, what I'll do is I'll quickly share my screen. All right. Oops, sorry. Oops. Can you see my screen?
Yes, we can see.
All right, thanks, Kadir, for the introduction. So over the next 15 minutes, what we're going to do is to share where we are in terms of cervical cancer screening in the 21st century and where are we going from here. So over the next 15 minutes, we'll be touching on 3 topics. Number 1 is an update on the current WHO cervical cancer guidelines, following which we'll touch upon the types of cervical cancer screening programs that utilize HPV DNA within the Asia-Pacific region. And finally, we'll show you what we as Roche Diagnostics are doing to enable cervical cancer elimination. So starting off with number 1, WHO screening guidelines. Now in 2018, Dr. Tedros mentioned that with HPV vaccination, screening and treatment of precancerous lesions, we can eliminate cervical cancer. In fact, in 2020, the WHO announced a global strategy to accelerate the elimination of cervical cancer. And as what Dr. Ida mentioned, this can be done through the 90, 70, and 90 goals. So what do these numbers and goals mean? Essentially, it means to have 90% of girls fully vaccinated against HPV by 15 years of age, to have 70% of women screened with a high performance test by the ages of 35 and 45. And finally, of the women identified to have cervical disease, for 90% of them to be able to receive treatment for those precancerous lesions or cancer. And therefore, in 2021, the WHO recommends the use of HPV DNA as a primary screening test rather than VIA or cytology. Furthermore, when using a HPV DNA test, the WHO suggests regular screening intervals of every 5 to 10 years. Which is why we are pleased to observe that within the Asia-Pacific region, there are currently 3 economies that have implemented HPV primary screening at the national level. And these economies include Australia, Singapore, and Thailand. So here's a closer look at the screening, what each country's screening guidelines entail. Now, starting with Australia, women aged from the ages of 25 to 74 years are invited to have a cervical screening test every 5 years. And in fact, now these cervical screening participants also have the choice to do self-collection. So these self-collected samples are then tested for the presence of HPV DNA. For women in Singapore, those that are between 25 to 29 years old, a pap smear test is recommended once every 3 years. However, once they reach 30 and above, a HPV test is recommended once every 5 years. Similarly, in Thailand, primary HPV screening is carried out for women from the ages of 35 to 50 years old, once every 5 years. So we at Roche Diagnostics, we have a crucial role to play in enabling this elimination of cervical cancer. And we want to be able to do so via our cervical cancer screening portfolio that we will introduce over the next couple of minutes. Now, when we look at the principles of cervical cancer screening, This involves three key pillars. Number one, to screen, which means to be able to accurately identify women at risk. Number two, to triage, which means to effectively refer HPV positive women for management. And finally, number three, to diagnose, to accurately identify precancerous cervical lesions, which should then be followed up with treatment like what Dr. Ida mentioned. So let's take a look at each of the different pillars. Here at Roche Diagnostics, we have three different tests, which will then answer each of the different questions with certainty. For screening, we have cobas HPV, which answers the question, is the cause of cervical cancer present? For triage, we have Syntact Plus, which helps clinicians identify if there are any oncogenically transformed cells present. And finally, for diagnosis, we have Syntact Histology, which helps to confirm whether cervical disease is indeed present. So starting with screening, we have cobas HPV. Now for cobas HPV, the Athena Trial, which is really one of the largest prospective cervical cancer studies that was done in US history, was carried out to really evaluate the performance of cobas HPV in three relevant populations: women with ASC-US, women with normal cervical cytology. This is where cobas HPV was used for co-testing with cytology. And in a third population where cobas HPV was used as a primary screening tool. So this is where it was used as a first-line test. Now, in this study, we enrolled more than 47,000 women that were of ages 27 and up. And so this was representative of the US screening population. Now, this study was carried out over 61 clinical sites in 23 states and 4 clinical laboratories. In this study, we compared both cytology with HPV testing. Now, when doing cytology and for sample collection, we use both SurePap as well as thin-prep liquid-based cytology media. So here, when a woman was found to be either PAP positive or HPV positive or both, they were sent for colposcopy. At the same time, a subset of women who were found to be negative for PAP and HPV were also sent for colposcopy. And this purpose was done to enable rigorous disease determination and to also review the potential of missed disease by looking at the negative subset. So let's take a look at the results. Now, from the Athena trial, as you see on the left over here, we find that the sensitivity of the HPV test, as shown in dark blue, is much higher than the sensitivity shown by PAP cytology, which is shown in the lighter blue bars. However, when we looked at specificity, now here we found that neither of the tests, whether it be HPV primary screening test or PAP cytology, had sufficient specificity by themselves to be used efficiently without further triage. And therefore, when we look at an effective screening algorithm or an effective screening strategy, in order to maximize disease detection, while at the same time minimize costs, harms, and inconvenience, it is important that an ideal triage test with high specificity is needed. So this would enable us to make the screening strategy as efficient as possible, and also that higher sensitivity triage test would enable these cases that were initially identified to be positive to be offered colposcopy immediately. Which then begs the question, right, like what Dr. Ida mentioned earlier. I mean, we know that HPV testing is really sensitive, but in terms of specificity, it's not as high as we would like it to be. And so some might ask, why not perform co-testing instead of HPV alone? So meaning we do both PAP as well as HPV for every single sample. Now, here in the Athena trial, as shown in purple, we found that there is actually minimal benefit of doing co-testing versus HPV alone, as shown in green. Furthermore, when we look at co-testing, now this is associated with increased number of tests and diagnostic procedures that may not necessarily benefit the patient, and at the same time have real costs to the health system. Which is why here at Roche Diagnostics, for triage, we then have our Syntact Plus test, which is used to answer if there are any oncogenically transformed cells present. So let's take a closer look at the dual stain Syntact Plus test. Now, Syntact Plus cytology is an objective immunocytochemistry test which uses two different biomarkers, P16 that indicates cell cycle arrest and Ki16 that indicates cell cycle progression. Now, the Syntact Plus cytology test is actually performed from the same cytology sample as the HPV as well as Pap test. So meaning that one sample can actually be used for two different tests if needed. Now, because these biomarkers should be mutually exclusive in a normal cell, because one indicates arrest, one indicates progression. Therefore, when we see it being co-expressed in the same cell, this helps to identify women with transforming HPV infections. And in fact, a single positive cell makes the case positive. So to evaluate the use of dual staining, the IMPACT trial was carried out. Here, it was demonstrated that dual stain helps to detect more cervical disease as compared to Pap, when we triaged HPV positive women, which were found to be SYN2, or HPV positive women that were found to be SYN3. And so here we found that dual stain can actually detect more disease than Pap. Furthermore, we also found that dual stain can be used to stratify risk. So if we look at the left column over here, now here we found that HPV screening helps to stratify which population is at risk and which population is not. Now with the use of genotyping, so for example, when we look at HPV 16 and 18, we know that this population is at higher risk and can then be sent to colposcopy for follow-up. But what about the 12 other high-risk HPV positive women? Now, for this subset, when we triage them with Syntact Plus cytology, so using the dual stain, now if they are found to be 12 other high-risk positive and dual stain positives, this actually indicates significant risk. And this risk is higher as compared to women that are 16 and 18 positive alone. However, if they're found to be 12 other high-risk positive but dual stain negative, this indicates a relatively low risk of having that disease. And so this will then be really helpful in enabling clinicians to better manage patients and to also give patients that peace of mind. And finally, in order to determine if cervical disease is in fact present, we have Syntact Histology. Now, traditionally, the diagnosis of cervical dysplasia is made based on histological interpretation of tissues that have undergone H&E staining. Like Pap cytology, interpretation of H&E slides can be objective. And sometimes when the lesions are very small, it can be missed. And therefore, by using a biomarker known as P16, which is found overexpressed in cancer cells, together with H&E stains, labs are able to add objectivity and highlight areas of interest. They're able to increase diagnostic sensitivity and specificity, thereby reducing the number of false negative high-grade results. And in our study, we also found that it helps increase diagnostic agreement between the lab professionals. So let's take a look at the certain study, which was done to evaluate the use of P16 and adjunctive aid to H&E staining. In this study that was done in 2018, a total of 1,100 biopsy specimens were used, and each of these specimens was stained with HNE as well as P16 separately. Now, in this study, the participants, or rather the consensus diagnosis was established by 3 expert gynecopathologists. It also included 70 individual board-certified surgical pathologists who then viewed the slides and gave their own diagnosis. So their diagnosis was then compared to the expert consensus diagnosis. And here it was shown that P16 helped reduce the number of false negative high-grade results and increase the diagnostic agreement amongst pathologists. In fact, P16 has also received FDA clearance in the aid of interpreting HNE slides. And so here at Roche Diagnostics, we really are leading the way in enabling greater cervical cancer prevention with our screen, triage, and diagnose approach. So like what Dr. Ida mentioned, we would also like to share that we recently launched our self-sampling claim for HPV testing, which we hope would help overcome access issues and also to empower women to better manage their own health by providing women with that privacy, ease, and comfort when it comes to collecting their own samples. And we are hoping that with self-sampling, this would help increase cervical cancer screening guidelines. It would help increase cervical cancer screening attendance, enabling us to achieve cervical cancer elimination. So with all that in mind, we would like to end with this key message. Knowing that cervical cancer is nearly 100% preventable, how can we work together with you to eliminate cervical cancer by 2030? With that, we would like to thank you so much for your attention, and we would like to take any questions.
Thanks, Andrea. And I have been told by the organizers that we are left with only a few minutes. So if there are a few quick questions, then we can try to answer them.
Thank you for a very elaborate, nice, good presentation. So very nice. I have a question with Dr. Andrea. I mean, you said you have a good experience with co-testing. So, like, is there any specific interval between the two tests that you do HPV test, for example, 4 weeks before, and you plan to do cytology 4 weeks afterwards, or you wait for a certain age, or you recommend co-testing for all your patients?
Sorry, maybe we'll let Dr. Ida take the first stab at it first. Yeah, for co-test, would you recommend?
So I'm not in terms of primary cervical cancer screening, I'm not a believer of co-testing because as you can see, the evidence from before, and we're talking about first ever screening in the community. We're not talking about screening after you had treatment for cervical cancer, cervical pre-invasive disease, or if they have persistent HPV infection after primary screen. Those are all secondary screening. But in terms of primary cervical cancer screening, I don't think co-testing has any place at all in the population screening because one, it is very expensive, and two, the benefit of co-testing compared to HPV primary screening is extremely small, and hence the reason currently in countries that advocate HPV screening in their primary screening, we all advocate HPV primary screening apart from co-testing. And co-testing basically means that doing a pap smear and an HPV DNA test together. There's not really any time in between them. You do both together, at the same time. And it depends on the facilities that you have. When we first introduced HPV DNA test as an alternative to cytology-only screening in Singapore, and we're the first to introduce it to NUH, the National University Hospital here, we did actually introduce it as co-testing, because one of the main reasons is because if you're trying to persuade buy-in from the stakeholders to use HPV DNA test to actually take away the pap smear that everybody has been using for 20 years, 30 years, 50 years. So it's very difficult to actually persuade current practitioners to do that in Singapore. So what we did initially at that time, because the most evidence are with co-testing, we introduced it first as co-testing. However, after 2 years of following up the data, introducing co-testing as an alternative to cytology-only screening in Singapore, we realized that our management of women with positive positive cervical screening results leaning towards more the HPV test results rather than the cytology result. And we realized as well that a lot of the positive cytology results with HPV negative are ascus or low-grade changes. And you know that in terms of the risk of having a positive HPV test, having a positive cytology test, but a negative HPV test, then the risk of the woman is still much lower. So we actually stopped providing co-testing, and we offered HPV primary screening from 2016. But it just means that you do both, the pap smear and the HPV test together. There's not really any time interval between both.
Thanks, Dr. Ida, for such an elaborative answer. Unfortunately, we have run out of the time, and I really enjoyed this session. That the session was very informative, and enthusiasm with the audience listening to the presentation was really heartwarming. And now I will request you, if you guys have any questions, please do contact us. We are ready to answer your questions. You can move your questions through iccbs team, and they will let us know. Thank you very much.
Ladies and gentlemen, there's a short announcement on the behalf of organizing committee that the next session will start at sharp 3:15. And then there will be 2 parallel sessions. One will start at the auditorium and the other will start at Ali Hall A. With this, now you all can proceed for a short tea break arranged at Golden Jubilee Hall. Thank you.